A very good day, my dear undergraduate and postgraduate students, and also the junior faculty. The topic that I am to take today is very simple: jaundice. Extremely complicated, difficult to explain, and almost impossible to justify. Yet, it is a university question and a common symptom that we do come across. Let us see what we can do with this topic. Classification is an aid to orderly thinking. So, here we have got a list of subheadings, which I always used to say. So, this is quite simple. Only thing the postgraduates will have to have in mind an entity called the jaundice in newborn, which is a university question for them. The other things can be the genetic causes, the differential diagnosis. And regarding the clinical symptoms, sclera, it's considered to be a misnomer because it is a membrane overlying the sclera that is becoming discolored. From the word Icteria virens, an yellow-breasted chat. That's what you are seeing over here, a bird. It can be yellowish or greenish discoloration or pigmentation of the skin, the sclera, and the mucous membranes. The normal serum bilirubin, almost less than 1 milligram, to round it off. And serum bilirubin, when it is more than 2, can be considered so. The signs and symptoms. Very simple. Symptom is something that the patient complains of. Sign is something that you elicit. And the eyes over here, the eyes can be the windows of the mind, or also they can be the diagnostic aid in clinical medicine. But be careful. This also can be a case of hepatitis. So these are the general features. I would like you people to go through it. Certain things are quite weird: headache, confusion, itching, etc. So you find that there is a plethora of sign and symptom that is coming along with jaundice. This is one of the prototype diagrams that I would like you people to kindly practice repeatedly. Courtesy Robbins Basic Pathology. So you find that there is a senescent or an old RBC and it contains heme, which gets broken down and gets converted to biliverdin and then to bilirubin albumin complex. This is because of the enzyme heme oxygenase and biliverdin reductase. After this complex, you find it becomes more soluble, it is able to enter the blood and into the hepatocytes, wherein you have got the bilirubin glucuronides, and there is a conjugation that is happening. So earlier until now we are having unconjugated bilirubin. Now there is a conjugated bilirubin. Within the liver, we can have both. And once it is conjugated, it is being excreted by means of the bile ducts into the intestine. And there are the various stations that I have mentioned. Kindly go through it. Because there is again a feature called as reabsorption and a de-excretion, enterohepatic circulation, or so. So this is something I try to store as much as points as well as distractors as well as informers for us, both from the examination point of view as well as from the NEET entrance exam point of view. So this is one condition where there is a hepatic porphyria. And my question is, what is the investigation that is being done? So, and again to the postgraduates, the slide for diagnosis. I do see that the hepatocytes are not having a clear cytoplasm. In fact, they are studded with grainy material, which we call as ground glass appearance, classical of hepatitis. The hemolytic jaundice, which we had seen earlier. And there is again a number of conditions over here, any form of hemolytic anemia. It can be what you say, intrinsic to the RBCs, it can be extrinsic, it can be membrane, it can be hemoglobin dependent, etc. Can lead to a jaundice. And what do you see in this picture? So I'm not going to give you the diagnosis, guess it. So the skull is showing some grass that is growing on it. Or if you want a clue, it is a hair on end appearance. Diagnosis. So these are all the conditions I would like you people to kindly go through. Then comes the hepatic jaundice. Whenever I say hepatic jaundice, the most common one will be the hepatitis. And whenever I say hepatitis, a viral hepatitis, it is the viral hepatitis and not until otherwise proven. It can be acute, it can be chronic, there can be toxicity due to drugs. Cirrhosis again can be an aftermath of all this, drug-induced alcoholic liver disease, and a few congenital disorders such as the Gilbert syndrome, Crigler-Najjar syndrome, and sometimes even leptospirosis, an infection, which can be deadly, in fact. So these are all the causes, and there is a list of this intrahepatic and then extrahepatic causes for obstruction or jaundice. Please kindly go through it. These lists will be coming to us repeatedly. Just see over here the obstructive jaundice. Some people call it post-hepatic jaundice also. So there are a lot of things over here, and this particular picture is showing an obstruction to the biliary tract. And therefore, obviously, there will be a stasis, and then there is a overflow of bile into the blood, leading to increase in serum bilirubin. Now, this is what you people are seeing, a number of conditions. Pancreatic cancer, biliary atresia, a question for postgraduates. Cholestasis in pregnancy, pancreatitis again, acute or chronic. And parasites also I have mentioned. So this again in the order of frequency, probably we'll have to remember the carcinoma head of pancreas and here the gallstones or cholelithiasis. That is one. And again, diagnosis. I want you people to diagnose it. You are all students for NEET. I'll be shortly putting up these questions again in our NEET shorts. So this is the case of opisthotrochus sinensis or plonarchus sinensis, a liver fluke. And this is something that I picked up from a dictionary, quite simple, which you people can draw in the exam, particularly the undergraduates. So you have the same story over again, the list of hepatic causes and the list of the obstructive or the post-hepatic causes. And coming back to this, you all passed your first year and you have completed your MBBS, the postgraduates. What is this test? The Vandenberg's test. Now, the types of jaundice and the laboratory findings. Always, classification is an aid to orderly thinking. On one, we have got the parameter. Two, the prehepatic, hepatic, and the obstructive tables. Mechanism is hemolysis. Here it can be defective uptake and conjugation. Obstruction, whatever be the source, defective excretion. Serum bilirubin unconjugated, both unconjugated and conjugated, conjugated. Urine bilirubin absent, present, present. And urobilinogen is increased in a case of prehepatic. Additional features will be evidence of hemolysis. All are given. ALT and AST will be increased, whereas here it is ALP, more than 3 times. Prototypes are hemolytic, viral hepatitis, and the gallstones. These are all the normal values. Again, I would like you people to kindly go through. Alkaline phosphatase is an important parameter for obstructive jaundice. There can be the reversal in the albumin-globulin ratio, so on. This again is very important thanks to the New England Journal of Medicine. I would like both the undergraduates and the postgraduates to kindly go through the list of investigations because any one such thing can be given as a question for us in NEET, which you people shall be shortly seeing in my classes. And what is this? You people have done your past and explain the principle of this test. So a table like this, definitely if I have a look at it, it will be very confusing. I will tend to look on or move on to the next slide. But see the way in which I am handling it. This is exactly the way by which the students will have to read any flow diagram. So when in doubt, to divide. So I have boxed in one. There is an entity that is called the hemolytic or the prehepatic jaundice. And these are all the causes over here. We have already seen the excess of hemolysis and the other causes. So it is unconjugated hyperbilirubinemia. So one box is completed. I'm forgetting the other things. I'm concentrating only on this. So again, I have magnified the same thing for your benefit. A hemolytic jaundice. And here again, it is for namesake a rapid recapitulation of the various stations of jaundice. Again, another box. After the hemolytic, we have got the hepatic. I have boxed in one. I have outlaid the others. So you find hepatic, it can be hepatocellular, whatever it is. Damage to the hepatocytes. No conjugation is possible, or in some cases, there can be the leakage of the conjugated bilirubin. That can be possible. So it can be Gilbert syndrome over here, or it can be hepatitis, cirrhosis, hepatocellular carcinoma, and so on. So I've got another list with me. Now, the obstructive. I omitted all the others. I have tried to take this particular one. So there is an obstruction, there is a compression. It can be head of pancreas, pancreatitis, various other causes for them itself. Polycystitis can have a list of other causes. There can be neoplasm, drugs, and so on. So obstruction, again, it can be extrahepatic or it can be intrahepatic. So the causes are again given over here. Cirrhosis by itself can be both obstructive as well as hepatic jaundice. So look at the way I had composed a very complex flow diagram. In fact, this particular one is different. This is totally conceptual, the best concept in my entire presentation. Heme, biliverdin, bilirubin, and then there is an excretion through the bile duct, goes to the intestine, converted to stercobilin and urobilin. There is an enterohepatic circulation, again it goes on. This kind of line diagrams you people will have to see repeatedly. Jealousy is the jaundice of the soul. John Dryden. So the eye as a diagnostic aid in clinical medicine. So here, what is happening? The entire cycle I have mentioned again another way. So this is quite simple for you to reproduce. I am not going to go into the contents of it. But can you guess the diagnosis in this case? Obviously, patient is not a child, but I can see the yellowish discoloration, a lemon-like tinge of the skin. And of course, the sclera is visible yellowish. So diagnosis. I'll give you a guess. It is a congenital disorder as such. What can it be? And what is this in this case? There is a neuropathology over here. So, now what is this picture? So I'm finding a child, obviously again the same story of the yellowish tinge is there, and it is being kept on a warmer as such. Some kind of phototherapy is being given, and incidentally this is another picture showing what kind of damage can occur in the brain. Your diagnosis, R.A.T.S with cerebral palsy. Thanks to Michigan. So the neonatal jaundice or jaundice in children is a question for the postgraduates. Go to the university question paper. And in this, there is an early, mid, and a late or a prolonged jaundice. Hemolytic causes such as incompatibility, G6PD deficiency, and congenital infections, including torch. In the mid, there can be a physiologic jaundice, another entity called the breast milk jaundice, and it is said to be due to inadequate intake of vitamins, etc. Hemolysis, Crigler-Najjar syndrome, and polycythemia. In the late or prolonged, you find that there can be a dark urine with pale stools, bile duct obstruction, atresia can be there, neonatal hepatitis, and unconjugated can be again because of physiologic infection, hypothyroidism. These are all the various causes that you people should be having in mind. Hypothyroidism strangely comes up. All looks yellow to a jaundice type. And I hope you people will be able to explain this test and Ehrlich's test. So side by side, I am giving you the list of investigations which have to be done in a case of jaundice. So this is again a beautiful diagram from your Robbins. Kindly go through. And the heme catabolism again, we have already covered. So this instant in children, somewhere I had picked it up and this is one. And on the other hand, I am finding the HPSAG investigations of the antigen and antibody. So this is important in a case of viral hepatitis and the window period, etc. You people can go through. Intrahepatic jaundice in adults, a lot of causes are over here, and it can be in the gallbladder and the bile duct, or it can be in the liver as such, and these are all the causes. A beautiful way of dividing it. This again, thanks to semantic scholar, both the intrahepatic and the extrahepatic causes of cholestasis. Kindly go through any one table which you are comfortable with, or at least remember the clinical mnemonic that is there. Thanks to them. So, jaundice B. What is the differential diagnosis of conjugated hyperbilirubinemia? Okay. So, once in the liver, you can find that can be the various infections such as that. It can be a biliary atresia, and then there can be the metabolic or the endocrine causes. That apart. But I'm more interested for the postgraduates. So can you tell me that there is also a stain for bile which is called by the name of the test called the Vandenberg's test. So it is a Hall's method by it. You get a same green color here. And there is another test called the Fauchett's test or staining method. These two you people shall be remembering and adding to your answers. Now comes the climax of the thing. This I have taken from a source and they have taken its cases notes. Great tribute to them. So the entire thing is given. What are all the factors? What is the screening to be done? And what is the clinical diagnosis? What is the line diagram? Where a conjugation takes place, reabsorption and a defecation. Stercobilinogen. And this is one that you people will have to remember. There is an unconjugated hyperbilirubinemia, then a conjugated hyperbilirubinemia. What are all the conditions regarding the breastfeeding, breast milk, etc., prematurity? What is the management? And then the unconjugated, again, hemolytic, non-hemolytic causes, then conjugated extrahepatic and the hepatic causes. Thanks to this particular reference, they made a beautiful table of it. I would like you people to kindly go through. And this, in fact, is the climax. Now, you people will have to explain. If there is a question on jaundice, what are you people going to write? So, what is the way by which you people divide prehepatic, hepatic, and posthepatic? Amongst the prehepatic, what are all the other causes? It can be the increased production, decreased hepatic uptake, or decreased conjugation. And in the hepatic itself, it can be because of the functional disorder and what are the enzymes which are elevated. Post-hepatic, it can be because of the compression from without and from within. A beautiful table again. Now, this was one that was diagnosed in a patient. I had shown you a picture of the patient earlier. So this is the liver that is there. Can you imagine the color that is there? And a special stain having been done. What is your diagnosis? We shall see this in shorts. Jaundice is the disease that your friends diagnose. William Osler, my pet teacher. Thank you.